Dear friends, I welcome you all to the 73rd episode of our prestigious Physician Forum of India, where we learn with fun. Slogan for today is Treat the Trinity. If I ask Dr. Prashar what is Trinity, he may say Brahma, Vishnu, Mahesh, may say Satyam, Shivam, Sudram. Here it is a bad Trinity. Three aspects of a major disease: obesity, diabetes, and severe risk. So we have to treat all the three simultaneously. Like you have three punctures in your car, you can't do with correcting one or two. All the three have to be corrected. So why you were not focusing on Trinity earlier? I think we never had any molecule which could do all the three in one go. If we look back, we did have sulfonylureas. They were good for glycemic control, but weight gain. Insulin itself, good for glycemic control, but weight gain. And not to talk about CV benefits. They were all bad for our heart. Minor or major, whatever. The newer insulins were better for cardiac safety, but we overall have a dilemma which one to use if we want to fix all the three punctures in our system. Incretins, they revolutionize the treatment. So even GLP-1 receptor analogs came some 15-20 years back, and they have been established now. But till now, we have been having them injection form. So but for those who don't want injections. तो दोस्तों ये आज की CME उनके लिए है जो ये कहते हैं कसम की कसम है कसम से कोई इंजेक्शन ना लग पाएगा हमसे, या जिन्होंने विश्व प्रतिज्ञा कर रखी है कि मर जाएंगे, टीका तो नहीं लगवाएंगे, तो लो भाई मत लगाओ टीका. Let it be a GLP-1 receptor analog in oral form, the oral Semaglutide, the one in its class and the first, which is available. Now the science has made it available, a peptide in the oral form, because usually we see the peptides are broken by the peptidases and nothing reaches blood. So here, new technology, the permeability enhancers with the technology of SNAC, we call it SNAC technology, they have made it possible that peptide can be used orally. So I invite Dr. Chauhan, the SA node of our Physician Forum, to give a talk to start the ball for ribosus, the oral peptide.
Am I audible?
Yes.
Am I audible without this?
Yes.
Friends, we are so privileged to have Dr. B M Makkar sir on the forum. We truly appreciate your presence. And I truly appreciate Dr. S Sengupta's initiative to get people from the national RSSDI to the forum. We will try and get more people, sir, so that we are in your good books. And we want to do good work, sir. We want to do right, sir. This is a very important CME, and I am so grateful to the wonderful marketing team of Novo.
Mic दे लो यार. Keep the mic there.
Okay, am I audible now? Yeah. So we'll be starting this CME. It's a very important CME. We have talked about a lot of molecules on this forum, and I have been in the forefront of talking about the newer molecules. We talked about incretins, we talked about sitagliptin, we talked about linagliptin when it came, and we have been such good friends with Boehringer over a period of time. But as people say, the only constant in life is change. And therefore, times they are changing. We have no new molecules on the horizon which are benefiting our patients on multiple fronts, and we need to understand their hemodynamics, their pharmacodynamics, and we need to bring it to clinical use to benefit our patients. So today is one such attempt to understand the pharmacodynamics of a molecule called oral semaglutide. Injectable semaglutide has been available in US for a long time, but oral semaglutide has been available in India for about a year, and it has picked up. It has picked up, and therefore it is important to understand what additional advantages we are going to get if we use this molecule for our diabetic population. So, it's the winning the battle against diabetes, addressing the trinity of weight, glucose, and CV risk. It's about vajan, it's about blood sugar, and it's about the cardiovascular risk. Dr. Tulsi had asked me, Yari, what is the weight of diabetes? I'll try and explain, sir, in the next few slides. I hope you will understand the difference between bloom and bleed after this, sir. Dr. Amrita, please forgive me and don't forward my comments to your husband. I am very afraid of it. Okay, I have no financial disclosures. There is no financial support. So we have three parts of the agenda. We have burden of weight and CV risk in diabetes. We have early weight loss and CV risk reduction in diabetes. So we'll try and understand if you lose weight early in the disease, does it benefit, and how much does it benefit, and tackling the trinity of diabetes with oral semaglutide. That is how you are going to get your data, if you understand that, okay? Even if you don't understand that, you say you have understood it, right? So let's begin the journey of this beautiful molecule called the oral semaglutide. And sir, where is the music? Where is the music? You promised me there will be music.
We can do without music right now.
Sir, yes, we can do without music. No problem. Anyway, it's not there. It's not there, and Dr. Makkar said it's not there. No problem. The journey was to begin with the famous Pakistan song. चलो दिलदार चलो चांद के पार चलो हम हैं तैयार चलो. So let's begin the journey of burden of weight and CV risk in diabetes. So it's important to understand the concept of uncontrolled HbA1c and excess weight and this impact of the dual epidemic. So it's important to understand that 88% of people with overweight or obesity at the diagnosis of type 2 diabetes are obese. So what is the difference between overweight and obesity? Can anyone tell me the difference between overweight and obesity? Dr. Kalra sir.
From BMI 18.5 to 23 for Indians, it is average weight. And if it is above 23, we are overweight. After 25, we are obese. This is for Indians.
Okay, so yeah, good. Sir, yeah, I'll just correct you, sir.
Yeah.
It's for females. For males, the normal BMI in India is from 18 to 24.9.
No, he is correct. He is correct.
Europeans के लिए बता.
He is correct.
Indians के लिए.
Sir, I have the European data here.
European data. India.
I have the European data here.
No, Indian cutoff is
So
Indian.
I'll show you the data that I have here. I'll just go through the slides and then we will see. So the difference between overweight and obesity, as I have on the slides, is overweight is any BMI which is between 25 to 29.9 kg per square meter. That is overweight. And then we have obesity class 1, class 2 and class 3. Therefore, RSSDI needs to look into it when these slides come into their domain, that they have to understand this. Sir, your comment please.
Sir, Dr. Kalra is right, sir.
Yeah, let him say. Because I have a slide set which is not Indian, which is probably European. Sir, your comment, sir.
So Sushil, what slide set has is the Western guidelines. Way back in 2008, we had the Indian consensus for redefining the cutoffs for obesity, overweight. So 2008, we had the first Indian consensus on redefining the cutoffs for overweight, obesity, and metabolic syndrome. And I was part of possibly the core committee or the steering committee. In fact, if you look back at the history, there was a obesity task force which was set up by WHO, International Obesity, International Association for Study of Obesity, and World Obesity Forum, something, 3 associations. And they gave something called a document called Asia Perspective, Obesity Asia Perspective, 2000. And they recommended that we need to have lower cutoffs for Asian population. And that was being followed for quite some time. And 2008 finally we had Indian consensus where Dr. Mukherjee, myself and Dr. Pradeep Chaudhary were the steering committee. And we had 200 people from Pan India involved in the consensus, which was published in the February issue of JAPI also. And since then the cutoffs are very clear. The BMI less than between 18 to 23 is normal. 23 to 25 is obesity. 25 plus 23 to 25 is overweight. 25 is obesity. 30 plus is severe obesity. This stage 1, 2, 3 is only for the Western classification. Okay. They go by 25 to 30 as overweight. 30 to 35 is stage 1, class 1, not stage 1.
Class 1.
Yeah. Then again these definitions have been modified further. Actually, if you spend time, you can whole day keep discussing definitions, because now we are not talking only on the BMI concept or waist circumference concept. We have to look at the level of comorbidity also. So there is something called EOSS, Edmonton Obesity Staging Class System, which has been taken into account. And the current, actually the term obesity again is being, challenged, because it is a misnomer. It doesn't convey the seriousness of a disease. Just tells you how much is your weight. Now weight does not mean fat. Obesity by definition is excess of fat in body to an extent that it is harmful. So it does not contain the amount of fat, it does not contain the harm related to obesity. So the new definition is looking at something called ABCD, adiposity-based chronic disease. And that is what is going to be the definition of obesity, which is being adopted worldwide.
Thank you very much, sir. Therefore, the slide set that I have from the company is all the European data and the European classification. I don't have the Indian classification. And therefore, it is so important to have the Indian perspective. So 88% of people at diagnosis in type 2 diabetes are overweight. 77% of people in India with type 2 diabetes have a HbA1c which is more than 7%, which is the ADA recommended target that all of us should have. So it's a huge chunk of people. All these 3 diseases, they are all encompassing. They have with the risk factors which overlap with each other. So if you have in type 2 diabetes, let us say obesity, smoking, history of gestational diabetes, race and ethnicity, high blood pressure, physical inactivity, high lipids, genetic factors, and polycystic ovarian syndrome as the predominant risk factors of type 2 diabetes. With obesity, we have some of these risk factors which cross over and contribute to obesity. And there are certain risk factors which are specific to obesity, like sleep patterns, socio-economic status, medications, mental health issues, and then we have the all-encompassing syndrome of CVD, which includes all these risk factors which contribute to each other's pathophysiology, each other's disease progression, and ultimately I would say manifest in form of CVD. We know that type 2 diabetes is characterized by certain inflammatory markers like IL-6, interleukin 8, interleukin 17, interleukin 22, TNF-alpha, interferon gamma. Same is the story with obesity also. It is also characterized by certain inflammatory markers which have been mentioned here. If you would see here, right, and some of them are common, and both of them contribute to systemic inflammation. And then there is this issue of insulin resistance in type 2 diabetes. We have often talked about it at length, which is, I would say, the common denominator of the common soil hypothesis in diabetes. Then we have elevated free fatty acids, triglycerides, which contribute to dyslipidemia, and ultimately all of them contribute to insulin resistance. All these inflammatory markers, insulin resistance, ultimately account for hyperglycemia on the side of type 2 diabetes. On the side of obesity, we have, apart from dyslipidemia, activation of the renin-angiotensin system, acute phase reactants PI1, and also hypertension, which ultimately account for certain very toxic effects on the blood vessels, the elevated endothelial and platelet dysfunction, oxidative stress, plaque development, and accelerated atherosclerosis. So this is the most important thing that happens with the combination of type 2 diabetes and obesity. And then we have an ecosystem which is going to promote a prothrombotic state, vulnerable blood vessels, and a compromised myocardium. And all this ecosystem helps with the promotion and establishment of CVD. So these three things, diabetes, obesity and CVD, तू इस तरह से मेरी जिंदगी में शामिल है, जहां भी जाऊं ये लगता है तेरी महफिल है. So they have so many factors which are common with them, and this is the data that I have for you. 88% of people with type 2 diabetes are living with overweight or obesity, while 31% of people with obesity are living with type 2 diabetes. 32% of people with type 2 diabetes have, you might just confuse that 31% of people with obesity are type 2 diabetes, while they are saying that 88% people have type 2 diabetes and obesity. Please understand, there is an element of overweight which Dr. B M Makkar and Dr. M L Kalra have just pointed out. Everyone is not obese in type 2 diabetes. There are people only with overweight, and therefore we have to understand that. 32% of people with type 2 diabetes have CVD, while 50% of deaths related to type 2 diabetes are because of CV causes. 29% of people with CID have diabetes. More than 2/3 of deaths related to high BMI are due to CV causes. So that is the importance of weight. And more than 80% of people with coronary artery disease are living with overweight or obesity. Now, we know that excess weight leads to excess cost in the diabetes care. So even if somebody has an extra weight, now these are European figures, I don't have the Indian figures, sir. These are the European figures. Somebody who is overweight and which has been defined as 25 to 29.9, redefined by Dr. M L Kalra sir and Dr. B M Makkar sir. So there is an elevated cost by 11%, even if somebody is simply overweight. So you can say that probably in the Indian context, 23 to 25, sir? Right. And if somebody is obesity class 3, that is a BMI of more than 40, the cost goes up as much as 46%. So weight is directly related to the amount of direct costs that are accrued by our diabetic population for the treatment and long-term treatment of diabetes. Coming to the second part of the agenda, early weight loss and CV risk reduction in diabetes. So if I can tell you the most important point in my presentation, if you have patients early in diabetes who are overweight or obese, the most important and significant aspect of the treatment is to get them to reduce their weight. If you are not able to do that, everything else is not going to work. That is my message. So, targeting the weight early, the upstream approach. And what is this upstream approach? So, weight loss is going to benefit both ways. It's going to promote glycemic control and it's going to impart cardiometabolic risk factors. We will have some comments from Dr. B M Makkar in the end. It is also going to disrupt the underlying pathophysiology and it is going to reverse or slow down disease progression. Whether it will reverse the disease progress is a matter of great debate, but it will definitely slow down the disease progression. Both of these factors are then going to help prevent micro and macrovascular complications. Then this is going to impact the trinity of diabetes. That was the topic. Okay? Right. So, how does weight reduction help our diabetic population? It reduces HbA1c. And is the amount of weight loss related to the amount of HbA1c reduction? Yes, definitely. If you reduce about, let's say, more than 15% of the baseline body weight, then there are very impressive results on the front of HbA1c. Similar is the story about the fasting blood sugar. More is the weight loss, more is the fasting blood sugar reduction for all our diabetes, and it is true. But if a patient starts to gain weight, does the HbA1c increase? Yes. If your patient is going to gain weight, then the HbA1c will increase. And similarly, the fasting blood sugar will also increase. So, both these parameters, both these important parameters in diabetes are related to the amount of weight loss. Weight loss is central to our story of this CME. So, greater weight loss was associated with greater reduction in HbA1c and fasting blood sugar. भैया weight कम करना है तो काम करना पड़ेगा. You cannot reduce weight without doing some work, without doing some homework. Okay? And therefore, just listen to this weight reduction leads to diabetes remission. It has been a great matter of debate whether weight reduction will lead to diabetes remission or it will lead to diabetes cure. We do not have any hardcore data and we will like to hear from Dr. B M Makkar sir whether weight loss can actually cure diabetes. We don't have any hardcore data as yet, but we have very good data on diabetes remission, clinical trials, weight management programs, intervention versus best practices care by guideline control. And it's important to mention that even a weight loss of as much as 5 kg is going to result in diabetes remission in 3.6% of the patients. If you could make it for 2 years, it will be about 5.2%. But if the weight loss is more, is the diabetes remission more? So if you have a weight loss of more than 15 kg, then the prevalence of patients who actually achieve diabetes remission is 86%. So that is the importance of weight loss. Now, therefore, greater weight loss led to greater proportion of patients achieving and maintaining remission. We are not talking of cure, please understand. We are only talking of remission. And if you would remember, from diseases like rheumatoid arthritis, there are phases of remission and exacerbation. So there is no guarantee the disease will not come back. आपने 20 किलो कम कर दिया, बहुत ही अच्छी बात है, लेकिन आपने 18 किलो गेन कर लिया, the disease is going to come back. There is going to be an exacerbation. Nearly 1.25 times odds of diabetes remission at 2 years for every kilogram weight loss. That is the importance of weight loss in diabetes. So you have to understand this and you have to work for this. Look Ahead is a very good trial which showed that benefit with even 10% of weight loss in type 2 diabetes and obesity had a 21% lower risk of composite outcome within 1 year. Whether it was the primary outcomes or whether it was the secondary outcomes. So what were the primary outcomes? The primary outcomes were the composite of these outcomes or occurrence of death from CV causes, non-fatal acute MI, stroke or admission to hospital for angina. So anything to the left of the curve of unity is beneficial. And what were the advantages of secondary outcome? Primary endpoints plus the coronary artery bypass grafting, carotid endarterectomy, percutaneous coronary interventions, admission to hospital for congestive heart failure and peripheral vascular disease and total mortality. So all these primary and secondary endpoints are actually all the clinical endpoints that were looking to benefit our patient, the diabetic population that we are treating with these molecules. दुनिया में थोड़ा देर से आया दुनिया में रहना है तो काम कर प्यारे काम तो कर लिया है weight loss imparts reduction in CV events and risk factors. Look ahead 1 year data, whether blood pressure, triglycerides, HDL and LDL. Just one message. More is the weight loss, more is the benefit, whether it is on blood pressure, remarkable benefits on triglycerides, mild benefits on LDL and some benefits on HDL. Now you know the whole HDL story with all the molecules which have been tried to raise HDL cholesterol. And you know very well that in diabetes, HDL has a great place. HDL is directly related to insulin resistance. HDL has a great role in metabolic syndrome. If you can increase HDL even by minuscule amounts, it is going to impact insulin resistance and it is going to impact the atherogenicity in diabetes. Therefore, any molecule which is decreasing LDL cholesterol and which is increasing HDL even by minuscule amounts is a molecule which we must look forward to using. Right, sir? Dr. Tulsi sir? Dr. Tulsi sir notes. Okay, so loss of 5% of body weight in the year following diabetes diagnosis was associated with improvements in risk factors and a 48% lower hazard of CVD at 10 years. Great benefit. Fine. So greater the weight loss, greater is the improvement in overall health and complications. So even if somebody loses about 5%, Dr. Makkar will say, I am sure say in the end, that ask your patients to lose weight. Even if he loses 1 kilogram, he is in the right direction. So even if he loses 5%, he improves on hypertension and hypoglycemia. If he happens to lose more than 15% of the baseline weight, then there are chances of diabetes remission. There are great benefits on CV mortality, and there are even great advantages in heart failure with preserved ejection fraction. Coming to the third part of the agenda of tackling the trinity of diabetes with oral semaglutide, very important part of the discussion. So semaglutide has a fatty diacid molecule, the C18 fatty diacid chain, and then it has a protein molecule, and it has got a spacer. The the diacid chain is attached to the protein chain at position 26 with lysine, and there are two substitutions at position 8 and position 34. And it's important to mention that the semaglutide has a 94% identity with the human GLP-1. It has a T-half of approximately 1 week, very long T-half. So even if your patient misses one dose, it's actually not the end of the day, right? And since it is a fatty diacid chain, conjoined to a protein, and you might be finding it so funny that we have now an oral GLP-1, because we have been so used to exenatide, we have been so used to liraglutide, dulaglutide. We actually now have a protein which can be absorbed orally. And how does that happen? So it is happening with the advantage of this molecule called the SNAC. There is a co-formulation with an absorption enhancer called the SNAC. The full form of SNAC being sodium Na2-dihydroxybenzoyl aminocaprylate. And how does this NAC help the molecule with its hemodynamics? So it protects semaglutide from breakdown by gastric enzymes. It allows semaglutide to be absorbed from the stomach. That is the most important thing, So that is one challenge which we have been having with oral insulin for such a long time, which I'm so glad that Novo has been able to overcome with this protein molecule. Promotes absorption from the gastric epithelium, and since they have such a beautiful bond and they have such a beautiful relationship with each other, each enhancing the potential of each other, you will be reminded of that famous song from Sholay. Okay, so let's right. So this is the bond, the beautiful bond between Amitabh Bachchan and Dharmendra, and this is semaglutide and SNAC, and this is about oral semaglutide, daily GLP-1 receptor, co-formulated with 300 mg of snack, and co-formulation does not change the chemical structure of either semaglutide or SNAC. They remain as distinct entities. Dharmendra remains Dharmendra, Amitabh Bachchan remains Amitabh Bachchan. Nothing. They only, and Sholay becomes a hit, super hit. Okay? So, what about the clinical trials of oral semaglutide? Coming to the heart and soul of the presentation, and I'll be requiring about 5 to 7 minutes on this, on these slides. So, there have been 19 clinical pharmacological trials which have been done. There is a one phase 2 trial which is going on. There are 12 phase 3A trials. There is one phase 3B trial. Total of 11,507 subjects have been enrolled, and 6,645 subjects have been exposed to oral semaglutide. So this is the whole program, which is actually called the trials are called the Pioneer trials, and the trials in the Pioneer series. Just give me about 5 to 7 minutes. This is the heart and soul of the entire presentation. I will require your attention, please. The trials in the Pioneer series are testing various aspects of the oral version of the glucagon-like peptide receptor agonist semaglutide. All the trials are sponsored by semaglutide's manufacturer Novo. And the full form starts with peptide innovation for early diabetes treatment, because Dr. Tulsi sir is going to ask me in the end what does Pioneer 1. So we have all these trials here: Pioneer 1, Pioneer 2, we have Pioneer 3 here, we have Pioneer 4 here, we have Pioneer 5 here, Pioneer 6 here, Pioneer 7, an extension of Pioneer 7. and Pioneer 8, and beyond that we have Pioneer 9, Pioneer 10, Pioneer 11, and we have Pioneer Plus, we have Pioneer Teens, and we have the SOAP. Okay, so we will just discuss in one line about these trials. I still have 7 minutes, and I'm sure that I'll be able to do justice. So Pioneer 1 trial population is treatment 9 people with type 2 diabetes mellitus here, and 3 doses were used: 3 mg, 7 mg, 14 mg in Pioneer 1. And what was the treatment was in monotherapy, so it was not compared to anything, it was in monotherapy. Reported in diabetes care 703 patients with an HbA1c of 7 to 9.5%, almost the identical population that we get in our clinic. They were randomly assigned to receive daily oral semaglutide 3, 7 and 14 mg. What were the results? Okay, what were the results by 26 weeks? So here we have the results at 26 weeks. By week 26, patients on semaglutide had average placebo adjusted HbA1c reduction ranging from 0.6 to 1.1%. So the minimum with this 3 mg and maximum with 14 mg. Okay, with all being statistically significant, the highest dose also produced a significant body weight reduction. That is what we are looking for our obese type 2 diabetic patients. So that is Pioneer 1-4. Okay, so Pioneer 1 done and dusted. Right. So let's come to Pioneer 2 here. Right. So which is the most exciting molecule in diabetes today? SGLT2 inhibitor. So let's compare this great molecule with SGLT2 inhibitor. And what is the SGLT2 inhibitor that we are using? Empagliflozin. And what is the maximum dose that we are using? 25 mg. So let's compare 14 mg with 26 mg. So let's compare apples with apples now. So let's see what is the advantage. So trial population consisted people with type 2 diabetes taking metformin only. The comparator treatment empagliflozin in the trial involving 821 participants, oral semaglutide 14 mg per day. 14 mg versus 25 mg. Produced significantly more efficacious results than the SGLT2 inhibitor empagliflozin. Semaglutide produced an HbA1c reduction of 1.3%, while empagliflozin 25 mg produced an HbA1c reduction of 0.9% at week 26. Okay, so here we have the standard of care, the best molecule available for us. Here, oral semaglutide in Pioneer 2 producing a statistically significant HbA1c reduction as compared to empagliflozin. The results were published in Diabetes Care. Larger effect of semaglutide than EMPA on weight loss. It is not only about HbA1c, my friends. It's also on weight loss. Oral semaglutide produced a weight loss of 4.7 kg with 14 mg versus 3.8 mg of 25 mg empagliflozin. Pioneer 2, Dr. Tulsi, done and dusted with. Pioneer 3. So we have Pioneer 3 here. Here. What is the next best molecule? Dr. M L Kalra sir said incretins brought a great ray of hope. Okay, but DPP4 inhibitors, the HbA1c was never more than 1. All right, you might say higher the baseline HbA1c, more is the HbA1c reduction. But what is actually, when we compare this molecule with DPP4 inhibitors, trial population people with type 2 diabetes taking metformin with or without the sulfonylurea. Standard of care for most of us. The comparative treatment was sitagliptin. Results published in JAMA compared semaglutide with sitagliptin. It proved significantly more efficacious at 7 and 14 mg per day. In 1026 weeks of treatment, it reduced HbA1c by an additional 0.5% over and above DPP4 inhibitor, and average body weight was about 1.6 to 2.5 kilograms. As you are all aware, ladies and gentlemen, DPP4 inhibitors are weight neutral. Okay, so I have covered Pioneer 3. Let's come to Pioneer 4. What was the population of Pioneer 4 versus GLP-1 receptor agonist? What is the best weight losing medication which is available today? Injectable liraglutide. Alright, so let's now compare oral semaglutide with injectable liraglutide. एक oral दवाई है, एक injectable medication है which we have been using, and now let's compare actually apples with apples. और अब देखते हैं कि oral versus injectable में कितना फर्क है. The trial population patients with type 2 diabetes taking metformin with or without a SGLT2 inhibitor. Comparator was liraglutide in the maximum dose 1.8 milligram per day. हल्की डोज में नहीं, पूरी डोज के अंदर. As reported in Lancet, daily semaglutide orally was non-inferior to the subcutaneous sema, and lira produced almost similar HbA1c reduction and significantly better than both of them, better than placebo. However, semaglutide produced significantly greater weight loss than lira. Liraglutide से ज़्यादा weight loss produce किया 4.4 किलोग्राम versus 3.1 किलोग्राम, and both were better than placebo. Pioneer 4 done and dusted weight. What is Pioneer 5? Pioneer 5 is people, which would actually interest my daughter who is a nephrologist, people who had a EGFR between 45 to 59. Alright, so the trial population patients with type 2 diabetes and an estimated EGFR of 30 to 59 ml per minute taking metformin, sulfonylurea both or basal insulin with or without metformin, conducted on 324 patients with moderately impaired renal function. Semaglutide 14 mg was associated with an average of 1% reduction in HbA1c versus 0.2 with placebo. Renal functions remain unchanged. That is the most important thing. Renal functions remain unchanged in both the groups during the 26 weeks of treatment. I have the entire data till Pioneer 11. What I want to tell you, my friends, is that I would like to go ahead and tell you that it was not only a superior HbA1c reduction across the Pioneer travels, whether it was in monotherapy versus AMPA versus Sita versus Lira versus even with insulin. What was the HbA1c reduction? Up to the tune of 1.5% as compared to the comparators. Okay, in a world where we have the best available molecules. And what about clinically relevant weight loss? It's not only about HbA1c reduction, it is also about weight loss, which is so significant in a metabolic disease. So, across the comparators, the weight loss was always higher with oral semaglutide, and it even reached to the tune of 5 kilograms. Right. When you lose weight, you lose two things. Either you lose body fat or you lose the muscle mass. Okay. Now, is it better to lose fat or is it better to lose the lean mass, the muscle mass? Fat. So, a threefold greater loss of mean fat over lean body mass observed with semaglutide. Right? But please understand that this was a trial done with injectable semaglutide, 1 milligram, which is not available in India. We don't have it in India. Right? But what it goes to show is that when you are losing weight, you are actually losing more fat than you are losing more muscle, and that is the ideal thing for our patient. Right? So oral semaglutide reduces body weight through appetite suppression. And what is the appetite suppression? I am on GLP-1, and I know that it was very difficult for me to eat. There was no appetite. 35% relative difference in energy intake, and it scored better. I mean, I didn't lose any taste of food. I was eating my food. I was eating less food, right? And it's not only about energy intake, it's also about reduction in the waist circumference, which is one of the hallmarks of metabolic syndrome. What is the ideal waist circumference a man should have? Less than 90 centimeter. And what is the ideal waist circumference a lady should have? 85 or 80? Less than 85. Less than 85. Right.
Height पे depend करेगा sir.
Right, sir. So oral semaglutide has shown cardiovascular safety and reduction in ASCVD risk factors as demonstrated by Pioneer 6, there was a 21% reduced risk of Cmes confirmed CV safety and non-inferiority of semaglutide versus placebo. We could only demonstrate non-inferiority in Pioneer 6 because it was an event-driven trial. Once a set number of events were reached, you could not go beyond that. Therefore, superiority could not be demonstrated. Oral semaglutide treatment with oral sema modestly lowers the level of LDL, cholesterol and triglycerides. Oral sema versus placebo treatment with oral sema reduced systolic blood pressure by 2 to 7. Then we have this the real pioneer data, the real world evidence on oral semaglutide. Oral semaglutide has been well accepted as a drug of choice for managing early diabetes in India. In patients with as high A1C as A1C of 8.9, no, I need to go. 90% were started for achieving better glycemic and weight control. 1 in 5 were started on oral semaglutide within 1 year of diagnosis, and 1 in 2 participants had CVD related history, stressing the need for effective treatment options. And oral semaglutide, just the last slide and the last zone. Practical considerations. So we have this wonderful molecule, friends. I have demonstrated with enough evidence. Robust HbA1c reduction, clinically relevant weight loss through appetite suppression, providing the efficacy of a GLP-1 receptor agonist in an oral formulation, proved cardiometabolic risk factor modification in CV safety, targeting cardiometabolic risk early in the course of disease. No dose adjustment is required in renal and hepatic impairment, low risk of hypoglycemia, and the first to be taken first in the morning empty stomach up to with 120 ml of water और 30 मिनट तक कुछ मत खाओ, उसके बाद मस्त रहो. And therefore I must thank you for your patience. Over to Dr. M L Kalra.
What a wonderful musical presentation by the master. Although we expected a few more minutes for our interaction to be spared. Dr. Chauhan, आज बहुत मजा आया. थोड़ा सा टाइम मैं सोचता हूँ कि ज़्यादा लग रहा है. Dr. S Sengupta, please let us hear from you the next part of it, the case-based studies. And we will try to wriggle out some time for our own interaction other than the panel discussion. Thank you, sir.
So thank you everyone. Thank you Dr. Chauhan, team PFI and Lovo for asking me to do this presentation. It's always a pleasure to be here. Doing presentations. Disclaimer, I don't have any music to go with my slides. It will be a very academic kind of presentation. What makes it extra special for me is that my bade bhai Dr. Makkar sir is here, which makes me a trifle nervous also, but hopefully should be.
Make a mic.
ग्रीन लाइट आ गई है कि नहीं है चेंज किया है
I am in South Indian election.
So, after that very exhaustive presentation by Dr. Makkar on the basics of Semaglutide, I will be carrying the discussion forward with the help of three case-based discussions. And these are not actual real-life cases, but they have been put up for the sake of carrying the discussion forward, and also to put forward the basic clinical relevance of the molecule in present-day context and how we can utilize it to the maximum in our clinical practice. My financial disclosure. So, I will be going through three case-based scenarios. Number one would be a recently diagnosed type 2 diabetic with low cardiovascular risk and high BMI. The second would be a type 2 diabetes with high risk of atherosclerotic cardiovascular disease. The third would be a long-standing type 2 diabetic with chronic kidney disease. So, the first one, let's see. So we are looking at a prototype patient, Varsha, 35 years old, recently diagnosed as a type 2 diabetic, 35 years old, body mass index of 28, waist circumference of 85, uncontrolled diabetic with normal blood pressure and lipid profile, comorbidities presently nil. Now medication, pretty much standard what we see in the initial phases of metformin 500 milligrams twice a day, sitagliptin 100 milligrams. Sedentary lifestyle, father had type 2 diabetes and died young from a stroke, started lifestyle modification 6 months ago. What are the patient concerns? HbA1c uncontrolled by lifestyle modification, that is the reason she has come to the healthcare provider. Concern on putting on weight with anti-diabetes medication. So, an overweight patient and obesity in type 2 diabetes is associated with an increased risk of several comorbidities. Renal disease, the risk of end-stage renal disease is up to 5 times higher in people with diabetes who are overweight or have obesity than in those with normal weight. Albuminuria, increased body mass index and waist circumference are significantly associated with albuminuria in adults with type 2 diabetics who are overweight or obese. Cancer, men and women with type 2 diabetes who are obesity have a 34% and 31% increased risk respectively of developing obesity-related cancer when compared with people with normal weight. Retinopathy, obesity increases the risk of diabetic retinopathy in people with type 2 diabetes by almost 64% compared to people with normal weight. Depression, which is something very common that we see in present day practice. People with type 2 diabetes and a body mass index more than 30 have up to 3 times higher odds of clinically relevant depression than those with people with normal weight. Obstructive sleep apnea, a 1 centimeter, mind you, just a 1 centimeter increase in waist circumference increases the likelihood of developing obstructive sleep apnea in diabetics. Mobility, people with diabetes and obesity have a 6 to 7 times increased risk of mobility difficulty compared with people without diabetes and normal weight. And this also translates into simple things like even attending to, routine day-to-day activities even in washrooms. It becomes a huge problem which we don't realize, but that accrues over a period of time. Now there is a 7 times increased risk of all-cause mortality in people with diabetes and obesity. Diabetics, 1 in 10 adults have type 2 diabetics, 20.4% are overweight, 67% obese, and 4 in 10 adults are obese, which leads to a 7 times increased risk of all-cause mortality in the age group of 51 to 61, which is pretty much a productive age for all concerned in modern day, people and population. So if one is cut short with things, obviously one gets a step back. Health risks have increased abdominal obesity, the mortality increases, cardiovascular disease and diabetes obviously increases, cardiometabolic risk increases, there is increased hypertension, increased risk of congestive heart failure, atherosclerosis, and risk of liver disease. So pretty much all the bad things that you're looking at in the entire spectrum of metabolic disorders. So treating early prevents long-term complications. This is termed as the legacy effect and is maintained regardless of later glycemic status. So if somebody is having a suboptimal glycemic control in the first year after diagnosis compared to, leads to higher risk of microvascular and macrovascular events in future. And a 1% reduction in HbA1c immediately after the diagnosis of diabetes leads to sustained reduction in the risk of complications, whereas delaying imposition, that is if you are not stringent with the patient, of a 1% lower A1C until 10 years after diagnosis of diabetes leads to a several-fold lower reduction in the risk of complications at 10 to 15 years, which automatically translates into lesser amount of improvement or benefits over a period of time. As you can see, if a person has had good control in the first year itself, there is a 20% risk of lesser risk of myocardial infarction and a 19% decreased risk of all-cause mortality compared to a risk of a 7% risk reduction in myocardial infarction and all-cause mortality risk reduction of 3% or so in people who are not controlled after the first year. So intensive treatment for newly diagnosed patients is necessary to avoid irremediable long-term risk for diabetic complications. Can I have a bit of less sound at the back, please? So in the Pioneer 1 subgroup analysis that we have seen, which has very elegantly been, alluded to and described by Dr. Chauhan in this last presentation, early initiation of oral semaglutide within 1 year of type 2 diagnosis, type 2 diabetes diagnosis results in a higher proportion of patients achieving near normal HbA1c. And if you see out here, if the patient is well controlled in the initiated with oral semaglutide in the first year itself, there is almost 45% of the people are able to achieve an HbA1c of less than 6%, whereas if it is more than 1 year, only about 31% people are able to achieve. And this accrues across the spectrum of the dosages used, and as the dosages go up, the A1C, the achievement of A1C becomes better, and achievement of a composite target of HbA1c less than 6.4% and plus a body weight loss of more than 5% is also seen in similar situations when oral semaglutide is introduced in the first year of diagnosis. Now, this has been shown in the different presentation in the present context in the earlier presentation, and oral semaglutide showed greater reduction of almost up to 2.6% of HbA1c with higher baseline A1c compared to all the other comparators in a very elegantly designed Pioneer 1 to Pioneer 8 trials. So in post-hoc analysis with baseline of A1c more than 9%, oral semaglutide resulted in an A1c reduction of almost up to 2.6%. Now, higher proportion of patients achieve significant weight loss with oral semaglutide, and a 5 to 15% of weight loss is beneficial in people with type 2 diabetes, and a 15% baseline weight loss, is associated with diabetic remission in certain individuals. But the cardiometabolic risk factor reduction and benefits accrue from even 5% weight loss. So if you are basically counseling your patients, please see to it that you do not start off very stringently at a very higher level of weight loss. Please tell them even 1 kilo is beneficial, 2 kilos is beneficial, 5 kilos is beneficial once you have seen whatever the baseline is. So every kilo counts. And 1 in 2 patients were able to achieve more than 5% weight loss, and 1 in 5 patients achieve more than 10% weight loss, which is very significant. The superior efficacy of oral semaglutide versus DPP-4 inhibitor in glycemic as well as weight reduction was seen in the Pioneer 3 trial already described. And as you can see, when compared with sitagliptin, 100 milligrams across the spectrum, semaglutide fared better. It also reduced waist circumference in comparison to MPA, CETA, and obviously placebo both. and the reduction in waist circumference would almost seem to be close to 5 centimeters, which was the estimated treatment difference versus placebo, which is very significant. We are looking at almost close to a 5 centimeter weight loss. So let's come over to the second case. The first case, she was initiated on oral semaglutide after counseling, and apparently she is doing well. The next case, type 2 diabetes, high risk of ASCVD. We're looking at Deepak, a 47-year-old, diabetic for 6 years on combination therapy with cardiovascular risk factors. He is an obese individual with a BMI of 30, uncontrolled diabetic with an A1C of 9%, comorbidities of hypertension, dyslipidemia and obesity. Medication, again pretty much standard that you see in routine day-to-day practice of metformin 1000 twice a day, glimepiride once daily and sitagliptin. Active smoker, sedentary lifestyle. Patient concerns are uncontrolled A1C, obviously, despite polytherapy. Weight uncontrolled by lifestyle modifications. Dosing schedule of multiple medications which makes him jittery. Concern about possibility of starting insulin and the addressal of cardiovascular risk factors. Now, what is the importance of multifactorial therapy? Early multifactorial therapy reduces risk of complications in people with diabetes. You have to look at parameters of glycemic control, platelet inhibition, dyslipidemia control, blood pressure lowering, and lifestyle modification. And in the very elegantly designed STENO2 trial, after 21 years of follow-up, mean 7.8 years of treatment, it showed that mortality was reduced by almost 45%. The survival increased to close to 8 years. Time to the first cardiovascular disease event went up to almost close to 8 years. That means it was staggered by almost 8 years. And microvascular complications were reduced by almost close to 48%. Now, how do you choose the right anti-diabetic? If you see in this table, GLP-1 receptor agonist, if you are considering the metrics of glycemic control, effect on body weight, cardiovascular risk factors reduction, pleiotropic benefits, and risk of hypoglycemia, the GLP-1 receptor agonist pretty much ticks across all the boxes in comparison to the other drugs that are there on the table. And semaglutide addresses mediators of atherosclerotic cardiovascular disease. Obviously, it improves glycemia, decreases weight, decreases blood pressure, improves the lipid profile, improves inflammation, and decreases the waist circumference. This reduces systolic blood pressure, and we know that each 10 millimeter decrease in mean systolic blood pressure is associated with reduction in risk with people of type 2 diabetes. There is a humongous risk reduction, 11% for any complication related to diabetes, 16% reduction in deaths related to diabetes, 11% decrease in myocardial infarction, and 10% decrease for microvascular complication. So, oral semaglutide was seen to improve systolic blood pressure by offering a reduction of 1 to 6 millimeters of mercury, and obviously the benefit accrues across the spectrum of patients that you treat. It improves the blood lipids. If you see both the metrics of LDL cholesterol and triglycerides, both were significantly reduced as compared to placebo, and the lipid profile improved. It reduces systemic vascular inflammation. Now, the metric study for C-reactive protein, which is a biomarker of cardiovascular risk and is often used as a prognosticator for long-term follow-up, and is produced in response to tissue injury, inflammation and infection. And you see a ACRP in these conditions, and compared to empagliflozin over a period of 52 weeks, which is actually a year, there was almost a 4-fold reduction in the improvement compared to empagliflozin. Now, what is the effect of dual therapy? With GLP-1 receptor agonist and SGLT2 inhibitors in cardiovascular outcomes, if you see the odds ratio out here, almost all of them are skewed towards the left side, showing the benefit of this. And dual therapy with GLP-1 receptor agonist and SGLT2 inhibitors compared to reference therapy showed a slightly lower risk of heart failure, but a significantly lower risk of MACE and all-cause death. I am sure we are clear about what is a 3-point MACE, what is a 4-point MACE, and what is a 5-point MACE. Are we good on that? So 3-point base refers to cardiovascular deaths, non-fatal MI and non-fatal stroke. 4-point base takes into account, in addition to these three, unstable angina leading to hospitalization, and a 5-point base talks about all these 4 metrics plus hospitalization due to heart failure. Now, the SOUL is an ongoing CVOT trial of oral semaglutide in patients with type 2 diabetes, where the primary objective is to demonstrate that oral semaglutide lowers the risk of major cardiovascular events compared to placebo. 9,600 plus patients of diabetes, more than all above the age of 50 years, with established cardiovascular or chronic kidney disease. A1C uncontrolled in the spectrum of 6.5 to 10%. Oral semaglutide 14 milligrams with standard of care titrated against placebo with standard of care. The trial information, first patient first visit was on 17th June 2019. It's a 5-year study. 1,225 events, 225 events are to be adjudicated, and the results are supposed to be out by June to July this year. The key endpoints being studied: primary cardiovascular death, non-fatal myocardial infarction and non-fatal stroke. Secondary, a composite CKD endpoint consisting of cardiovascular death, renal death, onset of persistent more than 50% reduction in EGFR, onset of persistent EGFR less than 15 ml per minute, or initiation of chronic renal replacement therapy. Also the secondary confirmatory endpoint of cardiovascular death, and a composite peripheral artery endpoint consisting of acute or chronic limb ischemia. The baseline data incorporated isolated or multiple cardiovascular conditions. So all the patients are basically sick patients, and these are the glucose lowering agents which have been there in the as the baseline. The ones marked out in red shows obviously despite anything, metformin continues to be used in a heavy dose for chronic kidney disease patient, which should be guarded. And despite all the Cmes that we have, and otherwise also SGLT2 inhibitors continue to be underused. Mind you, the SOUL trial which is being carried out is under the supervision of Dr. Michael from the US, and Michael A. Locke is the man who gave the incretin effect, the idea about the incretin effect. So out there in varied circumstances, you see SGLT2 inhibitors still being underused in spectrum that it should be used more, like coronary heart disease and chronic kidney disease. So coming to the third part, long-standing type 2 diabetics with chronic kidney disease. We have Dhanashekar, a 67-year-old gentleman with long-standing type 2 diabetes for more than 25 years with vascular complications, normal body mass index, but grossly uncontrolled status of an A1C of 12% and an EGFR of only 30 ml per minute. Comorbidities of hypertension, the patient is on ARBs and diuretics, dyslipidemia, on statins and CKD. Medication, the patient is on linagliptin, empagliflozin and insulin degludec, which is the co-formulation, 15 units twice a day. A reformed smoker and has a history of stroke 7 years ago. Patient concerns of reduced sleep, generalized weakness, swelling of legs and occasional feeling of giddiness. Now the care of people with type 2 diabetes and CKD is multifaceted and complex. We all know that very many patients are very sick and we just don't seem to see them improving, psychologically at times despite the best possible interventions. And they do incorporate specialists across the spectrum like nephrology, endocrinology, cardiology and obviously primary care. The steps of treatment, the bedrock remains lifestyle modification encompassing nutrition, exercise, smoking cessation and weight management. Going over to metformin, SGLT2 inhibitors, statin and RAS blockade with certain caveats. Going over to GLP-1 receptor glycemic control and blood pressure control. Now patient preferences, comorbidities, kidney function and cost, And KDIGO guidelines recommend long-acting GLP-1 receptor agonists for patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets despite first-line treatment or are unable to tolerate initial medication, so obviously you have to shift to other options. So lifestyle therapy remains the cornerstone. First-line therapy, the caveats are obviously you give metformin and SGLT2 inhibitors, but if the EGFR is less than 45, reduce the dose. EGFR less than 30, discontinue. Dialysis, obviously discontinue. For SGLT2 inhibitors, EGFR less than 20, do not initiate, and patients on dialysis discontinue. Additional drug therapies are these, and these are guided by patient preferences, comorbidities, EGFR and the cost factor, and includes patients with EGFR less than 30. Now, they have a well-established safety profile with no need for dose adjustment in patients with type 2 diabetes and CKD. Safety of GLP-1 receptor agonists in type 2 diabetics with CKD. The molecule retains glycemic efficacy and safety even in advanced CKD stages. But it is up to the doctor to decide whether he wants to give or continue with this in the overall spectrum of treatment that he is giving to the patient. The ADA supports the usage of GLP-1 receptor agonists in patients with type 2 diabetes and CKD. No dose adjustment of subcutaneous semaglutide, which is Wegovy, is required in type 2 diabetes and CKD. No dose requirement adjustment of subcutaneous semaglutide 1 mg is recommended for patients with renal impairment. And in patients with renal impairment, including end-stage renal disease, no clinically meaningful change in semaglutide pharmacokinetics was observed. Now, there are certain practice points which need to be seen. Prioritize patients, prioritize agents in the patients with which have documented cardiovascular benefits in such patients. Low hypoglycemia risk for GLP-1 receptor agonists is seen when used alone. Start with low-dose GLP-1 receptor agonists and titrate upwards slowly to minimize gastrointestinal adverse effects. Dose of concomitant sulfonylureas or insulin may need to be reduced to minimize increased hypoglycemia risk. Do not use GLP-1 receptor agonists in combination with DPP-4 inhibitors. This is a common mistake which is often overlooked. And GLP-1 receptor agonists may be preferentially used in patients with obesity, type 2 diabetes, CKD to promote intentional weight loss, but you have to obviously individualize the patient therapy. Now, oral semaglutide provides robust glycemic and weight reduction in patients with type 2 diabetes and CKD, as shown in the Pioneer 5 trials, which had patients with CKD stage 3 and uncontrolled diabetes. And the mean A1C change from baseline at week 26 was seen to be almost 1% as compared to placebo. And the mean body weight change from baseline at week 26 was seen to be almost 3.5 kilos versus 1 kilo of placebo randomization. GLP-1 receptor agonists exert cardionephroprotective outcomes through indirect and direct effects, though the exact molecular mechanism is still not delineated. But the potential kidney mechanism of GLP-1 receptor agonist is not well understood, like I said, but is likely a combination of indirect and direct effects. The indirect effects incorporate glycemic control, which is improved, blood pressure control, which is improved, and weight control, which is definitely improved. The direct effects are because of increased natriuresis and reduced kidney and systemic inflammation and reduced oxidative stress on the kidneys. Also, the reduction in the rate of EGFR decline was seen with semaglutide in the pooled analysis, post-hoc pooled analysis of Sustain 6 and Pioneer 6. If you see, as compared to placebo, the rate of EGFR decline was significantly lesser from a GFR of 30-60 as well as a normal GFR as compared to placebo. So semaglutide was associated with a significantly smaller annual decline in kidney function compared to placebo. Also, the benefit of addition of semaglutide as an add-on to insulin was seen, in which the change in A1C was significant as an add-on to insulin, and the insulin therapies which were used were both all three basal bolus and premixed insulin. So as the dose of semaglutide went up, the change in A1C was seen to be better as compared to placebo as an add-on. Likewise, in the metric of body weight, the addition of semaglutide led to almost a 3.7 kilogram weight loss as compared to placebo. Also significantly, proportion of patients achieving insulin dose, achieving an insulin dose reduction of almost more than 20%. And this was across the spectrum for all the doses that were seen with placebo, and also the proportion of patients with severe or blood glucose confirmed symptomatic hypoglycemia was similar as compared to placebo. So there was no extra risk of hypoglycemia with semaglutide. The renal outcomes in combination therapy of GLP-1 receptor agonists in combination with SGLT2 inhibitors, if you see, that fared better than a combination of GLP-1 receptor agonists and DPP-4 inhibitors or sulfonylureas or TZDs, and significantly lower risk of end-stage renal disease and EGFR decrease of more than 50% was seen in comparison of the reference therapy, and similar risk reduction was seen for chronic renal disease also. And as you can see, they were significantly better. You can see the blue dots on the left of the odds ratio out here as compared to the pink dots. So finally, oral semaglutide can be used in a wide range of patient profiles. Early in the course, recently diagnosed patients, as early targets can be met and better durability of glycemic control can be there. In type 2 diabetic patients who are overweight and obese, you see greater weight reduction and greater cardiometabolic benefits. In type 2 diabetics with multiple comorbidities, CKD, CVD, metabolic syndrome, and targeting multiple cardiovascular risk factor reduction is there. And in long-standing type 2 diabetics who are on insulin, there is weight reduction and insulin sparing benefit. So if you see across the spectrum, there are huge amount of humongous benefits which accrue when you initiate a patient on semaglutide during the course of anti-diabetic therapy. So thank you very much for the patient hearing. And it's my proud privilege to invite you to the RSCDI National Conference to be held on 14 to 17 November at Yashobhumi Dwarka, which is the largest convention center, and it is going to be a huge conference and you would expect you to be there. Also, secondly, coming Sunday we are having an overseas speaker who is going to talk about nutritional management and diabetes remission. I have just sent the particular flyer on the group. Please, and it's going to be there at the Park Hotel, so it would be nice to have you all out there. Thank you very much for your patience.
Thank you friends for patient listening. Some of people got restless also, I saw.
Light jala do.
We are now going to the next part. Yes.
Light jala.
This part. Sir, we have been booked for 10:30. तो अभी थोड़ा सा बाकी है. Sir, panel discussion. It will be crisp and short. I will ask a few questions to the panel, and we have third umpire also. So we won't take much time. We will give them all the time for asking all the questions. So. So before we move on to the panel discussion, just a few words from our legendary friend Dr. B M Makkar to comment upon what we have presented. Wajid, up to your mark.
Well, thank you for the honor. Before I go on to that, I forgot to appreciate the effort that has gone into getting me here, and I must put on record the persuasion by my dear friends S Sengupta and Sushil here. And not only that, they, this whole thing was decided overnight. They made sure that they got my profile, they got a memento made, and they presented within less than 24 hours. So I think kudos to the team for setting up this whole great meeting. Now I am no one to judge anybody, but I think we are moving into an era of changing concepts. We were, when we started from medical school, myself, Sushil, we have Dr. two here who happened to be batch senior to me. So we all understood diabetes as insulin dependent and non-insulin dependent diabetes. There was not type 2 and type 1. And this type 2 and type 1 classification came around 1998 when the cutoffs were defined for diabetes. And then we started realizing that obesity is connected to diabetes. But then we also started realizing that obesity possibly is playing a positive role in the development of diabetes. But we were focused on treating diabetes because we didn't know enough. So, when knowledge is limited, it is easy to handle a disease because you know only this much and you have to treat only this much. As the knowledge goes on expanding, it becomes more difficult to manage everything because now you know these many things, and you have to manage all of them. But in times to come, maybe for 20 years down the line, again somebody will be talking that we knew only this much 20 years earlier. So it is just beginning of understanding. And now we know that obesity is one of the major factors in development of type 2 diabetes. And we also have enough data from bariatric surgery and from now trials with the nutritional intervention, which was major trial was thyroid. And then we have step studies from Semaglutide. We have surmount studies from tirzepatide. And there are a number of trials which have shown that if you induce weight loss going in the range of 10 to 15%, and you do it early in the course of disease, you can actually lead to remission of diabetes, which is phenomenal. Second thing, we also have understood now that if you control glycemia early in the course of disease, it has a legacy effect. So if you achieve good glycemic control early in the course of disease, you defer the complications by 30 years, 40 years. Now in India, this is very pertinent because we get diabetes around the age of 40s. And now life expectancy is going to 80s. So everybody is going to live with diabetes for 30 to 40 years. And we have to make sure that we are not just controlling blood glucose, we are also preventing complications in our patients so that they live a good quality of life till their elderly age. And all these new molecules are not just giving us glycemic control, they are giving us benefits beyond glycemic control. Look at the data from pioneer trials, look at the data from sustained trials, which was the injectable version of semaglutide. Look at the new trials coming from tirzepatide or other newer molecules, or the data from glycosines. All these molecules are controlling glycemia. In addition, they are giving cardiovascular protection, they are giving renal protection, they are preventing organ damage, and they are giving a good quality of life. And you saw the last slides from S Sengupta's presentation where he showed the comparison of two drugs, GLP-1 added to different classes of drugs. And the best combination happens to be GLP-1 and SGLT2. And now we are no more looking at just control of glycemia, we are also looking at targeting the underlying pathophysiology. This story started with Defronza in 2008. Now, from 8 pathways, we are already at 14 pathways that are increasing risk of diabetes. So we are going to use more and more molecules. It is not going to be one drug therapy for diabetes, we have to be sure. And if you look at the new guidelines from ADA-ESD, earlier it used to be you control glycemia, A1C target is 7. As if it is not 7, then you add second drug to metformin. If there is ASCVD, start with GLP-1 and glyphosine. If it is no ASCVD or CKD, you can use any of the drugs. Now the current concept is start with lifestyle interventions, and 4 components of therapy need to be instituted simultaneously. Glycemia control, weight management, cardiorenal risk control, and organ damage. All need to be done simultaneously. So glycemia management is one component of therapy. Weight management is equally important component of therapy, and it is clearly recommended that the drugs that lead to significant weight reduction in addition to good glycemic control should be preferred drugs where these classes are coming up. And I'm sure we are going to see more and more of these molecules, and as of now the cost is high, but in due course cost will also become an important, lesser important consideration, because till last year DAPA and DAPA were very expensive. Now they are as expensive as sulfonylurea or metformin. So in no time all this will happen to the GLP-1 also. So I'm sure we are going to see very exciting times in management of diabetes in the West. Sushil made a mark that we have in near future we don't have many molecules. So just correction there. There are currently I think more than 20 molecules which will be entering phase 3 over next 5 years. And by the time you are going to see semaglutide going off patent, you will be having a flood of different molecules coming from different directions. And this is the area to stay. For physicians, you must stay in cardiometabolic medicine. That is the area to stay.
Thank you. Thank you for the insights.
So, friends, we heard the wise words from the legend. Incidentally, I was given 7 questions to be discussed in the panel. Single-handedly, Dr. Makkar has touched all the questions in nice details without asking. I am just stressing that obesity is 60% contributed by the brain. So we needed a molecule which acts primarily at the brain, also at other systems also. Then only we can control obesity and the threshold, the 3 parts of it, the diabetes and the cardiovascular. Sir, just wanted to know from you, in your practice, how do you help in mitigation of the side effects or tolerance part? How do you help the patients? Of course, we give smaller dose and any tips?
See, first thing is, I think the most important area where we lack it is education of the patient. Diabetes is something where patient needs ongoing education. So, once we are using any molecule which is likely to cause some kind of disturbance in patient's routine or can be perceived as an adverse event, person should be educated about. So fortunately I have a team which works with the patient. So I am not the only one, we have a full comprehensive work going on. So if you prime the patient and you start slow and go slow, then there is no challenge. There will be some patients who will not tolerate, there will be some patients who will not respond also, but majority of the patients you will be able to go through. And we are getting good results. I happen to be using the oral semaglutide right from the day it was launched, and I have been using liraglutide for many years. And the only challenge with lira was the injectable with a cost. Now you have injectable at low price because generic has come. So same will happen to Sema also in due course of time. And I'm sure they are going to get injectable Ozempic and it will be going in no time, which will again be add on to your portfolio.
So, some questions from Dr. Chauhan sir. Do you want to ask any question from Dr.
Yeah, go ahead.
Sir, wonderful lectures by our 2 esteemed senior physicians here. Sir, the real world evidence on the GLP-1 as we grow, along in our Indian setting, what's your take on how long should we use it? That's the question the patient always asks. Sir, the speaker is anyone on the chair. Sir, and the efficacy of the weight loss stops after a while. Right? You will only expect a certain amount of X amount where the body will say no more and that's why you maintain. The patient comes back, sir, do I need to stop this or continue this? What's your take on that? How lifelong and...
Yes, sir.
Okay, I am speaking on behalf of Sushil and Sengupta. So, a very important question. Now, first thing is how much weight loss can we achieve and how much, once it stops, what do you do? So average weight loss achieved in the trials with oral semaglutide is around 5% of 5+%. This is the dose that we are using, up to 14 milligrams. There is a trial which used up to 50 milligrams for weight loss, and there was a weight loss going up to about 15%, 13 to 15%. Now, one thing we have to understand is the concept of using anti-diabetic agents for weight loss or anti-obesity agents for diabetes is, a little confusing. Earlier, we were looking at agents like sulfonylureas, which will push out insulin from beta cell to lower glucose. In the same process, if you overdose, there was excess insulin secretion from beta cell, and one could get hypoglycemia. Now, GLP-1 analogs or GIP, or for that matter SGLT2 inhibitors, they do not act on insulin pathway. Glycogen or SGLT2 inhibitors act on renal pathway. They just increase the excretion of glucose, they don't lower glucose. GLP-1s act on insulin pathway. They stimulate beta cell to secrete more insulin, but it is a glucose dependent secretion. So once the glucose is normalized, the GLP action will subside. And if glucose is going low, the GIP will start going up and it will push on glucagon, so hypoglycemia doesn't occur virtually. And that is why you can use higher dose of these molecules. Now, once you are using higher dose of these molecules, this leads to increased central mechanism suppression, or action in the central GLP-1 receptors, and it has a profound impact on the GLP-1 activity. Now, once you are using DPP-4 inhibitors, you can block only GLP-1 receptors which are activated by native GLP-1. Once you are using GLP-1 analog, you are using supraphysiological dose. So you are actually activating many more GLP-1 receptors and you get pharmacological effect. So the smaller dose of these agents is good for controlling glycemia as well as lowering weight. But for higher weight reduction, you need higher dose of these molecules. So the injectable dose for semaglutide is 0.5 and 1 milligram for diabetes management. But for obesity management, it is 2.4 milligrams. Liraglutide we have been using 0.6, 1.2, 1.8. For weight loss, it is 3 milligrams. And now they are looking at even higher dose. So you have to use higher dose. Now, important question is, once patient starts losing weight, some point of time patients achieve a steady state and weight reduction stops. And now the question is whether we stop the molecule or not. Now, obesity is a disease. It's a now the current definition is it is a complex chronic relapsing disease with multifactorial etiology and requires multiple agents on long-term basis. It is a disease. Now, suppose you are treating a patient with type 2 diabetes, you put him on metformin, sulfonylurea, SGLT2, whatever. The sugar comes down. Now, do you stop the drug? If you stop the drug, it will go. You are treating hypertension. You are using 3 antihypertensive, 4 antihypertensive. BP comes down to 135. It will not go to 0. Will you stop the drug? If you stop the drug, it will come. Same is weight. It is not just weight. The first thing is we have to change the concept of obesity. It is not related to your eating or your physical activity alone. These are two modifiable factors which are contributing to obesity. There are multiple central mechanisms which are leading to obesity. There are multiple epigenetic factors which are leading to obesity. There is a lot of strong genetic predisposition. More than 300 odd genes have been identified to be associated with obesity, and there are some obesity associated genes, FOTT loci are identified, which are very important for obesity related mechanisms. So all these things are contributing. Now these things we can't change. We only know this much about the mechanisms. We are learning more. But now we know GLP-1, central GLP-1 is a very important mechanism. That's what we are targeting with newer molecules. Now, combination of GLP and GIP. GIP plays bigger role in weight loss. GLP-1 plays bigger role in glucose management. So then that is why where you are looking at tirzepatide, which is going to come by 2026 in India, most likely. And now we are looking at triple combination, GLP, GIP and glucagon. And if you look at the weight loss trajectory, we have seen only 17% with these molecules. The molecule is named retatrutide. The first phase 3 trial has shown weight loss going up to 26%, equal to bariatric surgery. So 5 years down the line, don't be surprised if you see bariatric surgery going out of fashion. So there is a lot of promising stuff happening here. And there is a lot of change in understanding of obesity and diabetes. So once you are treating, you have to use on long-term basis. Now, problem is the cost. India cost is a cost-sensitive market. We have to pay out of pocket. Insurance doesn't give us anything. So we have to create a balance. Now, in my practice, we continue them on, GLP-1s as long as they are willing to continue. Once they stop, we put them on a stringent lifestyle intervention so that they don't gain weight. And we also train them, if they are gaining weight, they should come back and restart with it. So, you have to work out your own local system to do best coordination.
Dr. Saigal sir, other questions, sir.
So liraglutide has been used for pediatric obesity, especially the genetic type of obesity. What is your take on use of this oral semaglutide for weight loss in children, especially obese children, and what age groups we can use it in? Is there any studies on that?
So there is a pioneer program looking at adolescent children. I don't think there should be any problem. But in children with obesity, I think we have to keep in mind that there are some single gene mutations affecting the leptin gene. So leptin deficiency is one of the major things. And if there is leptin deficiency which can be identified using leptin analog, which is the molecule name is metrelaptin. Metrelaptin, if you use, you can actually cure obesity in those children. But if it is, multiple factors or de novo obesity like you have in adults, then of course GLP-1 is an important thing. Then there is a data from metformin also. Metformin also has been shown to improve weight modestly in adolescent children, and it has been shown to be positive.
It will be important to mention, as sir mentioned, there is a trial which is going to be undertaken called the Pioneer Teens. Are going to be studied for oral semaglutide under the age of 18 years. People will be recruited.
More than 12? I think more than 12.
I will.
Usually it is adolescent age.
Yeah.
Less than 12, taking into trials is a big challenge. Who will give the consent?
So can I ask?
Yeah, doctor.
Dr. Kudar sir.
So you are using for weight loss more and higher dosage of injectable this liraglutide or semaglutide.
Yes.
So what is the harm in doing bariatric surgery? Because once we are now very safe anesthesia, surgery is very safe.
So there is, first thing is there is some element of modality still there. It is a operator-driven therapy. You cannot ensure everybody is getting the same result because operator differences are there. Second thing is, with treatment, actually if you look at GLP-1 therapy, there is reduction 20%, 20 to 26% reduction in mortality. In surgery, you are given, you say rest of the centers are giving only 0.5% mortality. Why would I take 0.5% mortality? Third thing is you have lost weight. Post-bariatric surgery, what is the therapy? Are they going to stay there? 40% weight regain. What do you do to those patients? Put them on GLP-1. Post-bariatric surgery, you have to put them on GLP-1 for rest of life.
But the dose will be very less.
No, same dose.
I don't think so.
So, sir, I know people are using. So, even for bariatric surgery, to prepare for bariatric surgery, they put them on GLP-1 alone for 6 weeks. Make them lose weight and then do bariatric surgery. Right? Then there is all kind of nutritional supplementation. So, why do a procedure when you have options?
So, any role of in your way of thinking, any role of bariatric surgery?
So, sir, there are cases who will not respond to the GLP-1. There are cases which are very severe obesity and difficult to handle with medical management. In my practice, fortunately, I have passion for obesity management and I am doing maybe now for 25 years. So the maximum weight I have handled is 210 kg with medical management. And I was not interested. I told them, man, go for bariatric surgery. This was young, 26 years boy, architect, and bad lifestyle, family history of obesity, diabetes, got diabetes, hypertension, obesity, and he didn't want to go for bariatric surgery. So he is in follow-up with us. Started at 210 kg. We have already produced about 40 kg weight loss. About 5 months, he has already lost 40 kg.
Thank you for your time.
Sir, Dr. Amish Vora is a DN in oncology. He is heading a very, very popular center in South Delhi called Hope Oncology Center. Here's the question.
Sir, I have 2 questions and 1 observation. One question is oral semaglutide or the injectable semaglutides have a black box warning. And a black box warning is something which one has to always look into it before. If you can highlight on that black box warning in the semaglutide injections.
You are talking about pancreatitis?
No. So I am talking of thyroid C tumors.
So it was a concern, medullary carcinoma of thyroid. It still stays on the warnings, but look at the large trials. Now we have CV outcome trials with multiple GLP-1 analogs. We have CV outcome trial with injectable liraglutide, oral semaglutide, injectable semaglutide, and now we are having ongoing trial with injectable semaglutide 2.4 milligrams. 70,000 patients are already enrolled. Select trial, and data is already out. There is 26% mortality benefit, and there is no increase in the risk of all these cancers.
I agree, sir. 3 months back, FDA had issued a letter to Novo Nordisk and Eli Lilly both. Eli Lilly is coming out with another type of and that is supposed to cause better weight loss than oral semaglutide. That you are not mentioning the black box warning. Kindly go back and mention the black box warning. That's the reason I say that. So second point is weight loss. Say 37 to 40%. Is the glycemic control better? Those who do not have weight loss, the glycemic control is not good.
Very interesting question. So the past study was the study which looked at tirzepatide 1.551 and 1.5 milligram. 5, 10, 15 for diabetes management. Semaglutide looked at semaglutide for diabetes management. All these studies, the starting A1C was 8.4%. What was the average A1C reduction? 2.2%. So from 8.4%, if you come down by 2.2%, you are in remission of diabetes.
Was it proportional to weight loss?
Oh yes. So
those who did not have weight loss, 60% of people, they will not have glycemic control.
Now let me come to another trial, direct, which was nutritional intervention, no drugs. 45% people had remission of diabetes. Those who lost more than 15%, 86% remission of diabetes. Those who lost more than 10%, 60% remission of diabetes. Those who lost 5%, again about 30% remission.
So it was directly proportional.
So it is directly proportional to weight.
So just one last observation, sir. I do an oncology practice and I would request everyone to look at that. Once a month, now I am getting one patient post-bariatric surgery. GLP-1 inhibitor मुझे नहीं, GLP-1 analog मुझे नहीं पता है, but post-bariatric surgery, sudden weight loss of 30 to 40 kg in last 1 to 2 years have developed cancers. I hope my observation is wrong for the benefit of 200 billion plus market of the world. But I am seeing once a month is not, and that is for a small practice like mine. It's not a small.
I totally agree, but let me tell you on the other hand, obesity is a big precursor for developing
We
cancer.
cannot induce diseases by loss of.
Yes.
Doctor, any particular type of cancer after weight loss you are...
GI malignancies and prostate. These two I have seen.
So we know that there is something called mesidoblastosis, that is de novo, regeneration of beta cells leading to hypoglycemic episodes. But for cancer, actually, bariatric surgery is again an area where you don't have very organized protocols or organized follow-up. Not everything is getting reported. That is the difference between medical studies and surgical studies. If you do a medical study, you have to have a protocol, you have to have a adverse event monitoring committee, you have to have adjudication of endpoints and everything. That is missing in bariatric surgery. So I think post-surgery surveillance is going to be the only way we can.
Dr. Brigmont sir, we have Dr. Saurabh Bhatta, MCH in Gastroenterology. He has a question.
He can answer this also.
So, I totally agree, sir. Now, bariatric obesity is a complete science, and every medical management or endoscopic balloon management or surgery is have one set of indications. My question is very linked to this discussion. We have used Semaglutide in the last 1.5 to 2 years in my practice, honestly speaking. And I felt that some patients are very intolerant with having a severe gastritis or a nausea feeling, and they take the medicines after 3 or 4 days or even a week or 10 days. So any specific, you can tell me any, any specific method to give that?
So first thing is educating the patient. First thing is educating the patient. So day one we tell them you are likely to get nausea. We don't frighten them, we tell them it is going to happen in 10 to 15% patient, and it is common. So first thing is don't eat heavy meals. Cut down your portion size. Second thing is be more on soft or liquid diet if you are having nausea. So if you vomit, it is not cumbersome, Third thing is, if you are having nausea, report back. We are sitting here, we will manage how we have to manage. So we start going slow. Second thing is, semaglutide has a long half-life, 7 days. You tell them to use alternate day also. It is not going to change much, but the side effects taper down. And if they go through that initial 7-10 days, then they are good to go for next dose escalation. So education and handholding is very important.
Any specific time you prescribe the medicines, like in the early morning or after 20?
So it is, oral sema is very specific how it is to be given, because it has the technology of SNAP. Now if you increase the dilution, it will be less efficacious. If you don't, you give less water, again it will not be absorbed properly. So you have to give it as first thing in the morning, with a measured amount, that is about 100 to 120 ml of water, and no intake of anything for next 30 minutes. That's the way it is to be given. First thing in the morning. Because to build the equivalent dose of 7, 1 week of injectable semaglutide, you need to give 7 pills. So once you have done 7 days, then it will start achieving the steady state.
After 10 days, 1 month you can use alternate day?
We can, technically speaking, but there is no data. There is no data.
Sir, can we prescribe this drug in PCOD? If yes, is it approved for
So, PCOD, I am not sure GLP-1 has got an approval. Metformin is certainly approved. So, I am not sure GLP-1 is approved for treatment of PCOD per se. But obesity management will certainly improve PCOD. So, there it has a big role.
Obesity with PCOD.
most of the patients with PCOD are obese?
Yes, but there are people who are non-obese also.
Yeah.
So there you need to have a different line of approach. But GLP-1 analogs are not approved as first-line therapy for NA.
Sir, Dr. Ashok Chakravarti, our legendary pediatrician from South Delhi, sir.
Dr. Makkar, nice meeting you and listening to your comments and excellent talk, of course, by both these speakers. I'm a pediatrician, so I have my heart with the kids. We have covered a rate of kids who are type 1 diabetes and they keep on taking shots. Don't, as you mentioned, there are no guys below 12 years of age. But do you force in future that some studies might be conducted that the kids are off the injection in glucose supply?
No, type 1 insulin is the answer. You don't have GLP-1 is not the option. But now we are looking at once weekly insulin. Ipodec is going to be there by year end or next year. So once weekly basal insulin is going to be.
That is some
And of course, you know, somehow I don't know why, but type 1 diabetes, insulin pump is such a wonderful option now, and we have closed loop pump now.
I know.
So if we put your children on this pump, immediately they are in, you know,
Thank you so much, sir.
Type 2 diabetes.
Type 1 diabetics are hardly obese or diabetic.
Sir, we have a question from Dr. Pankaj Mundra.
I am going to charge you now.
Sir, you see, there is always a cost of felicity.